So we want to start with co-creating pathways to community development for resilient health systems. And that session is split into two. The first part of it is a fireside chat. And the second part of it is a moderated panel session. So, Dr. Krishna Reddy, who I already introduced this morning, who wears multiple hats, from being a clinician to an entrepreneur to a co-founder of a large chain of hospitals, and, of course, the CEO of our Access Health Systems, where it's no longer about individuals, but about communities that he talks about. So people at the center for Dr. Krishna Reddy in multiple hats, and I invite you to be here, Dr. Reddy. It's a privilege for me to invite somebody who I've known and grown up knowing, wearing again multiple hats. Dr. Jayaprakash Narayan, JP, as he's fondly known to many of us, and who is a doctor by profession, has been an administrator as a part of the IAS for 16 years, chucked it all up one day and decided that people needed to be part of the center of his life. He's the General Secretary of the Foundation for Demographic Reforms and is a trained advocate for government and political reforms. If you hear him speak, you could sit there for hours and time would just fly past and you wouldn't know how much you learned or what you can take away. Dr. Narayan, or JP, has helped many of us walk the path when his Lok Satta actually contested the elections. I myself went to learn how to campaign and how we went from door to door. And that was an experience that I cherish forever, because there was no door that we didn't think that we could not touch. Jayaprakash Garu, it is our privilege to have you here this morning. And I'm emotional as I speak because I have known him as a young lady growing up. Thank you so much for accepting to be here this morning. And I leave it to two stalwarts with multiple hats to actually start this discussion on co-creating pathways for community empowerment and resilient health systems. Thank you.
Yeah, thanks, Suma. I think I kept hearing about JP, but I never met. So I take this occasion to actually interact with him as a part of these deliberations. As we said, we want a more informal dialogue, and you won't get a person of his stature because as a clinician, how a clinician understands individual patient requirements. Then as an administrator, how it translates policies into actions on the ground, reaching to the last mile. And as a representative of civil society, how he attempted to connect the civil society with the policy making or with the other systems. And also as a politician, because these are the different roles, he will have a different perspective on the issue of the role of community in strengthening health systems, in strengthening their own health, in becoming more resilient. As I mentioned in the beginning, and also most of the speakers in the morning session, that the 6 building block concept focused only from a top-down approach in terms of delivering healthcare to the people's needs. But only recently, there is an increasing awareness that the people being the center of health systems, they are best positioned to articulate what they need, when they need, how they need, and also the solutions that they are best positioned to co-create and suggest to the people who are actually going to implement that. So in this context, I would like to ask a few questions from Dr. JP in terms of how do we make the communities connect with the health systems and also with the decision makers?
Thank you, Dr. Krishna Reddy. Before going to the specific question, let me thank you all for the kindness. And let me also state that in the last 1 hour or so, I felt there was a bit of a sense of gloom and despair more than is warranted. So let me restore the balance. The world is an occasionally difficult place, but it's not a terrible place. We are in the best of all possible worlds. I genuinely believe that, because there is a gulf between what we can accomplish and what we are accomplishing, we are obviously filled with disquiet. But if you look at how far we've come, I think it should give us optimism. So I think while many concerns are justified, the notion that, my God, the world is collapsing is, I think, not borne by evidence. Pardon me for being a little bit of let's go back to our own country. At a time when healthcare was terrible, it's bad even now. But despite very low level of healthcare access and poverty and infections predominating, over 90% deaths were infections, the local government control was very effective, both in school education and healthcare. The Panchayat Samiti, the block as we used to call, the intermediate panchayats, about 100 villages, 200,000 population now. In those days, maybe 50, 60,000 population. They actually controlled the primary health centers. Now, instead of communities being empowered, what happened over a period of time is we disempowered communities. We institutionalized with great fanfare the 73rd and 74th Amendments to the Constitution of India. Well-intentioned, but a disaster. I can say it very nicely and politely over a long period. I can say it very sharply and swiftly. It created overstructured, underpowered, irrelevant local governments in the large part in the country. Completely disconnected the community from the governance, and governance that matters to their lives on a daily basis. Just to elaborate on this, the 73rd and 74th Amendments, they have 7,700 words, longer than the American Constitution, with all the amendments today. But it has simply not empowered the local governments at all, created overstructured, underpowered local governments. As a result, whatever government is doing, as Siddharth Sharma said, and I think Mr. Jalani also made the point, is top-down. The people are disconnected. If there's any saving grace in all this, with all its imperfections, is the private sector. Surprisingly, we all love to hate the private sector, and there are good reasons to hate them. But the failing is not that of the private sector. It is that of the governance apparatus, or lack of vision, and our over-centralized thing. And let me continue on this, just one more piece of evidence. We are all students of science and technology. We have to go by evidence, not by gut feelings. I don't know how many are aware. In China, an authoritarian country, the local governments account for 51% of the total government expenditure. 51%. India, a democratic country, a federal country, we have local governments accounting for 3% of the total expenditure. China has the highest in the world. India has the lowest in the world at local government level. Just one index gives you an idea. So we have to revisit this. I'm not one of those romantics who believes that locally everything is wonderful. No, not at all. I know there are rogues there, just as there are rogues at the state level, at the national level. I know we'll mess up our democracy, because democracy is prone to being messed up. That is the nature of democracy. But once you institute accountability at the local level, once there is a link between taxes and services, between the vote and consequences in the people's mind, then things will get set right. The self-corrective mechanism is missing. So what we're doing well is the mission mode things. No, We want COVID vaccines to be delivered to 1 billion people. We do very well. And we want to take care of a disaster relief. We do it pretty well. Relative to our resources and technology, we are pretty good in disaster management. Election conduct, we are world champions. Very defined, short-term, ad hoc operations, we do exceptionally well. But when it comes to real improvement of education, we are among the worst in educational outcomes at the school level. Among the worst. I mean, I'm sorry to say. I'm an optimist. I told you, please remember that whenever I make sharp comments. Because this can be set right. Optimism comes not from ignoring realities, but in facing realities and having the confidence and the institutional strength and ability to overcome that ugly reality. It's not romanticism. So our educational outcomes are appallingly bad. We can easily improve without spending a single rupee. Our healthcare outcomes, we all know the good things. We also know the bad things. The bad things first. 55 million people descend into poverty annually on account of lack of healthcare access. 55 million, almost the population of Britain or France, annually descend into poverty. Because we always think of poverty line as a stagnant one. It's not a stagnant line. It's a dynamic one. People get into poverty, get out of poverty. And therefore, on the margins of survival, it's very easy to fall into the trap of poverty because of healthcare crisis. And if you go by the disability-adjusted life years, many of us know the numbers. India accounts for something like 38,000 years lost per 100,000 population per year. That means 38% of your lifespan is lost, of which probably 10, 12,000 years cannot be saved. Old age. I'm now, Uma is reminding me of how old I am. I try and conceal my age. So inevitable. Old age is inevitable. Therefore, some decline in faculties is inevitable. But preventable loss of disability-adjusted life years, probably we're at about 20 to 24,000 years per 100,000 population. Half of it infections, half of it non-communicable diseases. So the good news is, while things are a little disconcerting on occasion, many of them are easily correctable. Our healthcare systems, however decrepit the public health system is, for every rupee we spend on public health systems, we're actually getting a value of 4 rupees. I know it's very difficult to believe. You go to a government hospital in a state and local setting as opposed to IMS or something. You'll see how terrible the infrastructure is. You get despair. But actually, when we do it reasonably intelligently, we're getting outcomes. But unless we redesign institutions, and that is the last point I want to make about engaging the community, I have lost faith, despite my optimism, of the government's capacity to deliver out of altruism, except in mission mode operations. So only thing that will work in the government system is some kind of public-private partnership with competition and choice embedded in the model. Look at Prime Minister's Ayushman Bharat. What we started in Andhra Pradesh as Arogyasri. Many other states embraced it. To the extent that this is succeeding, what is the source of success? Because there is competition among service providers and there is choice for the patients. If you are forced to go to a Mohalla clinic in Delhi, however well-intentioned it is, there's a limit beyond which it will not work. So if you embed competition and choice at a low cost, I think we can significantly alter the outcomes in the country because we can't afford to spend too much money. We are now spending 1.2% of GDP on healthcare in this country, of the GDP from public systems, one of the lowest in the world. At most, we can go up by another 0.5, 0.6. When I was in NAC some 20 plus years ago, the then government said, we'll make it 2 to 3%. There was such a big range. We hope somewhere at 2 will land. We're still at 1.1, 1.2. I don't have any expectation that given Indian fiscal compulsions, we can reach 2 or 3% casually. If we increase by 0.5 to 0.6% of GDP, gradually that too, you can't do it overnight, over a period of 3 years, let us say. And this, if you spend an equivalent amount of what the finance minister gave away this year on the tax exemption, ₹1 trillion. And I'm not opposed to tax exemption. Who wants to pay taxes? Each time I sign a check, I hate it. I mean, you don't get service. So I'm not opposed to that. I know Nirmala well, so it's not a attack on her. But the point I'm making is this is affordable. If you spend something of that order, gradually increasing to that level within 2 to 3 years, but wisely, based on competition and choice. And if you don't force people to go for a simple ailments to a tertiary care center, AIMS Delhi has 10,000 outpatients a day, the world's highest number. It's not a source of pride, it's a source of shame. That simple ailments, the people are compelled to go to India's apex medical institution, is actually a sign of collapse of the healthcare system. So you must reimagine the healthcare system. And if you do that, and if the burden on the tertiary care system is substantially reduced, and primary system actually works, particularly in the context of non-communicable disease now rising in importance, 63, 64% of mortality, or 68% of the mortality in India is on account of non-communicable diseases. We're still thinking of 50 years ago, infections being the dominant killer. To the extent they are killers, that must be eliminated. And that can be eliminated. But the growing challenge is epidemiological transition. Therefore, unless you really have a graded system, accessible, accountable, competition and choice-based, at a low cost, involving public and private sector, you won't get people's involvement and you won't get earn the people's trust. But we're so close to it. India is a champion in many respects. With all the imperfections, there's so many advantages. Our pharma sector and vaccine sector is a world champion. The lowest cost, best quality. The number of doctors and nurses we produce is unimaginable. 125,000 doctors a year and roughly equal number of nurses every year. And we can ramp up production tomorrow like matchboxes. Only thing is quality issue, but quality can be set right. Our assessment system is bad. We can easily set that right. Our private sector, with all the complaints that we make of it, is now bringing down the costs to the rock bottom level, maintaining quality. The hospital where you worked, or many of the hospitals, the heart surgery or knee surgery or kidney transplant or vascular surgery, most sophisticated interventions, we have the lowest cost in the world at world-class standards. So we can leverage these strengths and significantly translate this into outcomes for the ordinary people, the billion plus people who really are suffering. I'm a great optimist, and I believe that we are very close to that. My appeal is, from grand concepts, you must translate it into tangible action points. I heard some wonderful things today, but I'm trying to see how much of it can ordinary people grasp and make that relevant to their lives. Unless we translate this into ideas and actionable points that make an impact on human life at the grassroots level and capture their imagination, it will not be a politically relevant thing.
Thanks, JP. I think it's a vast coverage of the ground level realities and also both positives and the negatives. Taking forward the point that you made, that the governments alone cannot actually meet the challenge. I'm trying to pose the question in terms of the concept of triangle of governance. That means the government alone is not responsible for the governance of the social systems, but it is the triangle having the people, the private sector, and the public sector. You rightly mentioned that the private sector is essential in terms of addressing the challenge of people. At the same time, the people also are responsible and accountable for their own health. So in this context of this triangle of governance, what do you foresee in terms of translating this concept into kind of an institutional mechanism on the ground?
Krishna, I'm glad you made this point. UK, somebody mentioned the National Health Service. I'm a great admirer of that. Who is not? I mean, anybody in the healthcare sector would love it because the world's pioneering thing. They're spending 10% GDP. Ask anybody in the UK as a patient or any doctor or a resident, they have deep disquiet. While the broader objective that nobody shall be denied quality care for want of money, that's an absolutely worthy objective. But the way that was translated into action, where it was wonderful and romantic and effective initially, now we're finding it's simply not working. The US is spending 18% of GDP on healthcare, about half of it from the government, half of it from the private insurance. US has the lowest outcomes in the world among the rich countries. It ranks about 39th or 40th. That's not a good medal either. You ask anybody, a doctor, I'm sure you are very familiar. Even doctors are terrified of falling sick in the US with all the insurance gold-plated coverage. So we have to find a model which is uniquely Indian, but adapting the best practices. And that's where, how do you incentivize the individual to preserve her health? Some years ago, I was in King's College, London. Somebody introduced me to Dr. Michael Edmonds, the world's leading diabetic foot specialist. He's a doyen in that field. So the moment I mentioned that I'm from Hyderabad, he said, the diabetic capital of the world. See, there is a tremendous epidemiological transition in the world, in the country. And a lot of it is preventable. Everybody knows type 1 diabetes probably is not preventable because we don't even know why it happens. It's not an immune thing. But type 2, even if there is a genetic trait, your diet, your lifestyle, your exercise, in 95% cases can substantially bring blood glucose under control. And your metabolic syndrome or overweight. India today, for a country which was on the verge of starvation for a long, long time throughout our historical memory, now has perhaps the world's largest number of overweight people. Maybe China is a little larger there. I don't know, but we are somewhere there. So they can easily be set right. So what has Singapore done? And that's what makes me admire Lee Kuan Yew even more than normal. Way back in 1960s, about 60 years ago, he realized, well, that aspiration of everybody getting quality care is very vital. The way you go about it is not the NHS model. He realized that the NHS does not give incentive to the individual to preserve her health. So he designed a very, very complex, intelligent model where the individual takes charge of the health, and at the same time, if you are unfortunate to fall sick, and you're not really left to your own devices, you can be taken care of. So I think there are ways of doing it. And in India too, we are well placed not because of any design, because of the government's failure today. Private sector is about 70% of the total healthcare. Public sector is only 30%. So whether you like it or not, you have to have private sector. And whatever you do in private sector, it has to be based on cost effectiveness because nobody else is funding. And your Aragyasri, etc., while they are good, PM's Ayushman Bharat, etc., still the amounts we're spending are very marginal. I think the national program is spending about 7,000-8,000 crores, 10,000 crores, which is peanuts for India. Good. No, to the extent it's happening, probably it'll ramp up a little bit, but we can't really go excessively. We can't spend trillions of rupees. India simply cannot afford that. So unless we design a healthcare system where the individual has an incentive to preserve her health and protect her health, and then have a graded system of primary care, secondary care, and tertiary care with primary care physicians acting as gatekeepers, and unless we have risk pooling mechanism which is sustainable, we will not achieve those goals. But I think now we have enough global experience and our own need and our own institutional strength that points in that direction. But unfortunately, even today, our imagination is American. Because, who doesn't love America? So, insurance, good. I'm all in favor. I have insurance. But remember, 90% of India's workforce is the unorganized sector without a monthly wage. Insurance has never worked anywhere in the world without a regular payroll tax. Therefore, I think, who was mentioning I think Siddharth Sharma again was mentioning the 10 crore Indians at the apex, the 30 crore who are okay, but the billion people. If you want to reach the billion people, you have to devise innovative models. For the rest of the 400 million people, you have all your insurances, other things have no quarrel. They'll take care of themselves. But I think there is a way forward.
I think excellent points in terms of the governance and the context-specific models. I think we cannot copy one with the other systems. And the role of community itself, what they're going to pay and other things, I think our subsequent panel is likely to discuss on that in terms of the role of the community per se, the role of the governance, and its partnership with the private sector. Of course, we didn't have the time to deliberate on how to have the right oversight on the private sector so that public are assured of the quality and safe care. I mean, so
One word on that. The Parliament enacted a law called the Clinical Establishments Act. Well-intentioned. In my judgment, a potential disaster. Because the regulation must promote transparency, informed choice, and self-correction rather than control and price determination by some government babu, which in India inevitably means massive corruption and in general a disaster. Now, as you know, healthcare is a state subject. But under the Constitution, the Parliament is empowered to make a law if two or more states request the Parliament to intervene and make a law for the state subject. It applies only to those states. The other states can adapt that law or adopt that law by an assembly resolution. But the funny thing is, once you adopt it, you cannot come out of it. It's a constitutional infirmity. It's a state subject to its fundamental law. One day Supreme Court will deal with that. So when it came to my notice, for instance, Andhra Pradesh was enacting or adopting this law, I contacted the Chief Minister immediately and got it stopped. But Telangana, by the time we realized, the law was already enacted. So regulation, yes. But in our anxiety to over-regulate, if you decide what is the price structure of every intervention, disregarding the quality of personnel available, the experts available, the infrastructure available, the reputation they enjoy, it will only spell death net to our private health sector. It doesn't solve. So what is required is complete transparency. Who are the people? What is their professional? What are their professional credentials? What is the infrastructure? And what is the pricing that they are offering? Then let the citizen make informed choice. And once there is competition and choice, we make the best decisions. So regulation, but in our anxiety to regulate private sector, and there are many tales of abuse of power in private sector. There's necessarily asymmetry of information in private sector, in healthcare. Obviously, there's a need to regulate, but if you over-regulate, it will destroy India's healthcare. Today, we are getting $13.8 billion from overseas patients offering healthcare services. India could easily rise to $100 billion. It could be a great money spinner as well as employment generator. So don't kill the baby with the bathwater. You must be very careful about it.
Thanks, JP. I think we had a wonderful wisdom coming through the deep understanding of health system and the social system and the governance system. I think most of the students of public health and the health system sitting there, you won't get a better teacher than JP. Thanks, JP, again. And of course, we'll continue to have your words of wisdom while being in the audience. I hand over to Uma for taking forward the next section of the community.
Dr. JP, I don't know how you keep all that knowledge where you do. And you continue to inspire us, inspire me more than ever. And how you actually distill it to make it simple, effective, and at the same time, awe-inspiring, while you provide us with a feeling of hope and never despair. It's always a pleasure, and I don't think we can stop. If we give you a whole day, which we will at some point, I don't think we would be less awestruck than we are today. So at some point, it's going to be more than a half-day session that we'll have with you and have everybody listen in, maybe online, may not be in person. It is indeed a privilege. Thank you. And I have now the privilege of calling my own panel up here and having to introduce myself too. So I am Uma Isola, for people who don't know me, a PhD in Health System Strengthening, the Global Director for Communication and Partner Engagement, Access Health International. But more than that, I have spent close to 40 years in healthcare and across various kinds of healthcare. I've seen it from 7 days of cataract surgery where people didn't move their head to 10 minutes when they walked away. And of course, now for the last 10 years, serving communities more than ever. I've also been an active engagement for various community engagement activities and probably the country's first patient-designated patient advocate 38 years ago. So now I have the privilege of asking or requesting actually, Dr. Sundar Raman T. He is a heartthrob to many over here who have seen him as the former executive of the National Health Systems Resource Center. He has actually made it happen to come all the way from Pondicherry to be a part of our conclave today. He serves as the professor and dean of School of Health Systems Institute, Tata Institute of Social Sciences, Mumbai. And then more recently, he's the global coordinator for the People's Health Movement, went across the entire region and is an advisor to the WHO CRO. A privilege to have you here, Dr. Sundar Raman. Prabhat Sinha and I went to the same college, not at the same time. So again, very pleased to invite you. He's our Director for Government and Public Affairs, Boringen Hingeman, and Prabhat leads the CSR of BI in India and is a part of the country's leadership team. Prabhat has done extensive work across patient advocacy, groups, supported cancer-based research, last mile activities in various public health fora. Thank you, Prabhat, for being here. Dr. Rajvi Joshpuria, a physician and a public health expert, works as the senior coordinator at SEVA and focuses on community health and wellness for women. SEVA was introduced to us. I think I have gone and been a part of SEVA's recipients of the lovely work that they have done when they started with the Lucknow Chikankari work, I think almost more than 40 years ago. Rajvi has taken, along with Rima Ben, it to many notches up, where they have women in communities that have actually benefited significantly, not just from the work environment, but on self-employment and health and wellness. Thanks, Rajvi, for being here this morning. Ratna Devi Garu, please to come up. She is the co-founder, CEO of Dakshama Health Education. A decade in the government service and spent 20 years leading public health initiatives of both national and international NGOs. An advisor to WHO headquarters, works significantly on making a difference at the ground level for social impact in community engagement. I look forward to having Sachin Golwalkar. Morning, Sachin. An independent social impact consultant now, but has had several strategic leadership roles, both in United Way, Delhi, and several other organizations that have looked at diverse domains as maternal health, child health, public health advocacy, early child care, mental health care, and inclusive education. He brings to us the philanthropy perspective and how things have changed. I am not going to set any context in the interest of time, but going straight to the questions. And I'm going to give you each your sets of questions, which you know, and let you take forward the answers as we take. Of course, I will invite my dearest friend, Dr. Sundar Raman, to go first. And how can community service organizations be effectively and integrated into governance and health is my first question to you. The second is your personal experiences of grassroots levels, because the moments that you have spent in transforming health systems, top down to bottoms up, is something, and equitable at the same time, is something that we'd like to hear. On the side, if you would touch on some of the biggest challenges that you have experienced across from NHSRC to who you are today? And what would you want to share with us?
And all of it in 5 minutes? That is a challenge, Oma. So I think you set off a one day's session on that. But I get the spirit of it, and I wouldn't be here if not for Oma's persuasion. Because at bottom line, there's so much of a thing. And I'm quite surprised that you chose among my background to put the People's Health Movement in front. I must tell you that I'm much retired from everything, and it's 3 years since I have been global coordinator. That's all in the past. I continue to be associated with most of the organizations that I've worked in. So, in some sense, any of them, but I'm former that, not presently. I advise and speak wherever anybody asks me. So, and don't give unsolicited advice.
Refuse to speak more than I
So that's the real background on that. But this is something close to my heart, and I am very happy that you have involved me. And I think that, the nature of community services and the nature of engagement with communities, there are many, many frames. In the 70s and 80s, we had a lot of NGOs in community service who were doing model building, who were actually creating models of community service delivery, health service delivery that were to influence the world substantially. There was for some time the model of the Aroles, the model in Jamkhet. Then you had Mandwa and Antya. You have Gadchiroli, and there was this whole thing. And to a large extent, even the Alma-Ata Declaration and the whole spirit of this drew from those models. By the 90s, the government to this role of model building didn't happen, but a lot of people who had been engaged in that process got into advisory roles. But there was also the period when people who did not, this whole thing also got into an activist and advocacy roles. So that was the sort of movement into which my own association was. But this did not exclude participation when working with public health systems where there was space to strengthen it, to strengthen public services. So this is really the particular takeoff. Governments, meanwhile, had come to a situation where we were using NGOs more like as contracting organizations rather than model building. That particular phase, when they were looking to it as models, had sort of ebbed away, though there were people who were doing it on the ground. A substantial break from practice occurred under the National Health Mission, where community engagement became mainstream, one of the main features of architectural correction, as it was called. And it was called architectural correction to differentiate it from the earlier structural adjustment related health sector reforms, which were really talking more about private sector participation. And we were talking about strengthening public systems under non-market based principles. And therefore, you had the introduction of the village health and sanitation councils. You had encouragement for community service related service delivery through NGOs. We had encouragement for, say, community monitoring by NGOs. You had a very large community health worker program that was to a large extent mentored by Asha Mentoring Group, as it was called, to bring in civil society direction into the nature of the program. It was understood, in fact, the secretary and I remember discussing it, and this is a different character, we said, from the general staff. And to maintain that character, you need a civil society participation. And a group was created over there. The whole experience of the Mitanen program and that how that was scaled up and into the Asha program. So there was this whole period that happens between 2000 and let me say about 5-7 to about 12-14 period, when you have this whole notion of community engagement as a purpose in itself. I mean, you can look at it as instrumental. You can say, okay, this is the amount of infant mortality reduction that village health and sanitation committees bring about. That's one way of looking at it. There have been good studies that have shown that such gains are there. There's no doubt about it. But a much more substantial way is to see community engagement not as embedded in our understanding of what health is. Health is not something that is manufactured in hospitals. Health is something that is an outcome of the processes of how we live our lives within, embedded in society. So the way the community decides to be empowered is health in itself. It's not doing that for getting health. Unfortunately, as the move happened later and later, this spirit of the enterprise, the spirit of what community engagement is meant to do, became more and more instrumentalist on that sort of issue. And at some point of time, even more redundant. So you think you can do the ASHA program without a significant community engagement, accountability, or responsibility, then you face the reverse issue of having a huge union worker issue, and then you are trying to handle it within a bureaucracy, and you're not able to actually bring these two elements together. You have the village health and sanitation committees where most of the places you have just let go of it because you're not able to see, you're looking at it in measurable outcomes, you're not looking at it as inherent to the process of being healthy, and therefore I think that at some point the notion of health and healthcare, what it really represents, is at the heart of this community service enterprise. And there should have been space for anybody. I mean, while we are rigid on this, so if some young person wanted, so in NHM, I remember taking this upstairs and losing it again and again at the Mission Steering Council. We would write the proposal, we will write it, and it will go there. And I even don't want to name the ministers who will particularly put it down because they didn't want any of this nonsense. But the issue of community service delivery, there was a rule that said that at least 5% of service delivery should be through such model organization, so as to set a certain baseline sort of comparison. We never got that through. We got shut down. But having said that, that spirit was still there in framing of community engagement. So I think it's a process, and I think we are not done with that process. It continues because that is not a pathway, that is also the purpose, where the pathway and the purpose is there. That eventually what you need in health systems are health systems where communities are active participants and the persons who are responsible for the development or keeping people healthy, and not merely beneficiaries who are sort of receiving a hand down from a system. So I think this whole vision of what community participation is about and what it should be going is the heart of the question.
Thank you. Thank you so much. Prabhat, you've been in private sector all along, but you've done community service as a part of private sector. You represented various organizations from Novartis down to Boehringer Ingelheim today, and in between Pfizer. And you've seen that private healthcare has its role to play, but you've also seen that private healthcare has supported significant amount of public health enhancement. And you have been a champion of communities. I want you to share your experience and share how it has actually changed and what were those lived experiences that you have.
Thank you, Umaji. And I think it's rare to have a conference like this, which starts with a session thinking about community and patients. And I think this needs a clap from all of you. And have you ever heard about any organization, whether it's pharmaceutical or hospital, which doesn't say that we are not a patient-centered? Everybody says that we are a patient-centered or a community-centered delivery partner, right? But yet we see a difference in the way that patient or community is kept at center. It's a journey. And as Umaji was saying, I started working in public health system Ratnaji was our super boss at that point of time when I was in UP districts running around immunization and improving maternal and child health care. From that time to this time, I think a lot of things has changed. That is something that we should be happy about. I was listening to JP sir and I could relate what I had seen 20, 25 years back. The whether patients are incentivized or people are incentivized. Even now when I need to go for my diagnostics about some of the health condition, I will always be fearful taking that report back home. You know why? Because if I worked on something and my indicator has come down, it is not highlighted. It is only highlighted some of the factor which is not being, done. So there is no incentive. It's always what is highlighted is for the healthcare provider to see that this is out of range. There is nothing which is green, which is incentivizing me that I have really put my effort in last 3 months to bring something back. That's why I'm saying that it's a journey and how we see. But glad to share that I think even in, I'll talk about from the provider perspective, there has been a lot of change the way organizations have started understanding that unless and until patients or communities are involved, they are not to be kept in the center and let other stakeholders revolving and dancing around. They have to be engaged. And I'm saying it purposefully because I've witnessed this, that we say that they are there, but they are only there. We don't reach out. And some of the practices within some of the organizations, when I started working, I saw that how, there has been conscious effort to listen and understand what patients or community want. Ratnaji is going to talk more about that, so I'll not touch on that. But 3 things what I want to summarize. One is that acknowledging that there is a wisdom, there is a value of community or patients that exist. And they exist, they do exist. In any disease area, they do exist. We may not have vision, we may not have that sight that to identify where they are. In every community, there are leaders. And today, if we talk about Asha worker, these are the leaders who have been groomed, trained. So they existed unless and until system recognized. So acknowledging is the first thing. That's a ABC. The B is building capability. And I think we all have seen that how much capability building has gone in last 2 to 3, 4 decades from a lot of community-based organizations. I see less of it now, probably. I may be wrong, but I see less of those effort that was there to build capability of small grassroots organizations, building change agents or Methanians. And even today, they are the backbone. They are the bridge because community recognizes them, they trust them. So the second is the building capability is so critical. And the third one is the collective action. We talk about action, but do we recognize that the patients or communities are active participant? Do they get seat on the table? Do we leave that seat for them to sit on that seat? Because we believe that we know everything, but there are many things that we don't know they know. And that quadrant which we don't know they know, do we made conscious effort to learn and bring that? And I think as I was saying that even private sector organizations have started realizing that unless we consider them as a very active participant in the whole ecosystem, there's no place for us. You have to recognize it's a journey. As I say, for anything to happen, it will not happen overnight, but there is a very conscious understanding, acceptance that you need to recognize them, you need to learn from them. Otherwise, even a leaflet which goes, and I remember I used to work with one of the company and we produced a patient education material for a disease, a cancer, which was hitting people with almost 60 plus year, a blood disorder. And when it was, and the company did a patient advisory board to understand that, how these materials are reaching to them. So one of them said that, who designed this leaflet? So, and he said, if you know that disease is hitting people with 60 plus, why the font size is 8? Have you ever considered that the font size should be 14 or 16? Otherwise, I will not be able to read it. Now, see, this insight will only and only come once, you really think from that side. And see, but because there was a conscious effort, the font size of that leaflet, which was a self-reporting outcome kind of template, the font size was increased. And the uses of that particular tool increased by over 60%. So there is a merit, but do we come to that stage where we say that whatever we create for patients or community, we first vet it with them, and then only we come? Otherwise, people in marketing, public health, we all consider that we know it all, and we will design it for ourselves. But the messaging, what they want, they may not get it. So that's why I again want to sum up this saying that acknowledging, building capability, and including them in collective action is so critical. And I think we are on that path. There's a miles to go in this, but I think we have started that journey in a positive way.
Prabhat, great insights and great learning and great sharing. Ratna Devi, you chose that path and you walked a different path to a different drummer's beat, and you have done it globally. Want you to share those drums, those beats, and want you to make sure that people understand what patient advocacy is about and how those beats actually make the difference.
Thank you, Umagaru, for those eloquent words. So just starting from where Prabhat left about co-creating, I just wanted to remind the audience of the title of this session, which says Co-creating Pathways to Community Empowerment for Resilient Health Systems. A lot of very big words. First of all, when are people co-creating with anybody? No policies, no documents, no rules, no guidelines ever have any inputs from communities. It's always they are the recipients and they are the ones who receive those services. They are the beneficiaries. This is a kind of terminology that is used, that we are the service providers, we are the healthcare providers, we are the policy experts. So we make the operational guidelines, and we feel that the people who benefit from these operational guidelines will accept it in the way it is delivered to them. But that is not true. And we just heard from Prabhat, as simple as a font size. So when we do something called community advisory boards or patient advisory boards, these are the inputs that we receive. What is important to them? Most often, healthcare systems are designed around the clinician's perspective. So the clinician will see what is a clinical outcome. So for a patient with hypertension, for example, the clinician will see whether the hypertension is maintained. But if the medicine is giving them a constant headache, the patient will not take that medicine. And therefore, there is a problem of adherence. But you have not understood that what is important for that patient is to be able to go to work and be productive. They are not bothered about whether the hypertension is under control or not. They want their life to be better for them. So quality of life has much more meaning and importance than clinical outcomes. But how do we design our clinical outcomes? Based on what they are taught in textbooks. We do not ask the patient, are you feeling good? We look at their charts, we look at their lab reports, and we then conclude that we have done a good job because their cholesterol is under control or their hypertension is under control. But are they feeling well? We don't ask this question. So that's one part. Second, and this is discussed in most of our patient organizations or conclaves or summits, is everyone thinks healthcare starts once the patient enters the hospital. That's not true. Neither does the patient, the healthcare start once they enter the hospital, nor does it end once they leave the hospital. And we know for sure, especially in long-term chronic conditions, that 80% of management of healthcare happens in the homes. So if I'm a diabetic, I might need to visit the hospital to, have my annual checkups. But everything else is managed at home, whether it's my lifestyle, whether it is my food, whether it's my mental health, everything is managed at home. But nobody teaches the community, the family, the caregiver to be able to have a model where healthcare is managed at home. So unless we are taking feedback from communities, feedback from caregivers, feedback from family members who take care of people with chronic conditions, our healthcare is never going to deliver the outcomes that we require. In May 2023, WHO held a series of consultations. So it was actually over 2 years, from 2021 until 2023. WHO held a series of consultations, and what came as an outcome was a framework document that talked about meaningful involvement of people living with non-communicable diseases. And if you read this framework document, it says what communities should do, what people with lived experience should do, what countries should do, what healthcare providers should do, and what agencies like WHO should do. And in that document, it also says that people who have a lived experience, who are living with a condition, should be treated as experts at par with the healthcare providers, because they know their condition much better than anybody else in the system does. And we've seen it again and again, that patients who have lived their condition know their medicines, know which medicine works for them best, know when they have problems if they are not taking their medicines, know how to overcome those challenges if they have not had their medicines on time. And they are able to give you nuances which probably as a healthcare provider you're not able to understand because you have just 10 minutes with the patient. The patient lives with the condition all their life. So they have much better understanding. And in conditions where the patient is not able to take care of himself or herself, it's the family member who knows much more about the condition than the healthcare provider. We all know that even in the best of healthcare systems, healthcare providers do not have enough time to spend, quality time with the patient and understand their condition. So unless we bring the communities to be able to co-create in the true sense and understand from them what is most important to them, we would have failed. We can have discussion after discussion, we can have policy after policy, but we will never get the outcomes. And that is why we have all these framework documents, we have all these policies, we have multi-stakeholder engagement mechanisms, but our healthcare indices are not improving. We are failing in our sustainable development goals. We are far behind what our sustainable development goals tell us to achieve. We are nowhere near 2030 goals. The other thing is communities are people who are living within an ecosystem. It's not just healthcare. It's nutrition, it's roads, it's transport, it's housing. So unless we bring all of these, and that can only happen when you're talking to the person. So you've given the best medicine, but that person has no food. How are they going to take that medicine? They have no livelihood. How are they going to manage their day-to-day sustenance? So you have to bring the communities to the center to be able to understand what is their problem and address those problems if you need good healthcare outcomes. I'll stop there.
Ratna, you and I can go on about this. Each of us can speak a day about all the challenges, and very well put. I am myself a patient advocate and understand where it goes, and also can't wait to see big experts because they don't have time to listen. So I'd rather go to a newbie and be heard rather than go to the top 5 and not be heard. And that's about patient advocacy too, So, Rajvi, Seva is Seva. So, Seva has brought together hundreds of people, thousands of people, changed the lives of communities across. Started with 2 women who decided to make that happen, and now has reached generations of people who want to be a part of that journey. Please share more about Seva, being a part of the Seva.
First of all, I would like to take this opportunity to thank Access Health, Dr. Krishna Reddy and Dr. Uma to give us an opportunity to be here, present here, and share our experience. Second, before I begin with sharing what our experience so far with healthcare and communities has been, before we just mentioned that, JP sir just mentioned that 90% of the population belongs to the informal economy. And then we were discussing about incentivizing why should they focus on their health. Why can't we consider their livelihoods or their well-being to be an incentive? Because for informal sector workers who are toiling day and night, health is a very critical determinant of them being able to earn their livelihoods. There will be days when their chulas won't burn if they aren't able to get their livelihood for that day. So that for them is an incentive. Now, coming back to answering your question, when we are talking about building resilient health systems, it is not defining what resilience for them is. It is building that system block by block. For them, knowledge is action, knowledge is power. Health is not mere absence of disease, but it is focusing on their overall well-being. It is on what for them it is their social, mental, and physical well-being. So it is not defining disease in a medical jargon, but it is helping them overcome the treatment hesitancy, or it is demystifying or debunking the myths that community have, or simply turning medical insights into actionable steps that can be followed at community level. That is what knowledge for them is. Second, we have our own cadre of healthcare ambassadors who belong to the community, who have that trust base. Earlier, Ratnaji said that patients don't have someone to go approach and listen what they want. So these healthcare ambassadors, they are trained by Seva cadre of doctors. So they know what basics of each and every disease is. They know what basics of NCDs are. They know what occupational health for them is. They know what nutrition is. So they listen to what patients want to tell. Second is empowering these women to have access to digital literacy and financial literacy. Very often, be it climate shock or be it pandemic, be it financial shocks, a lot of workers, a lot of members have to make a hard choice between seeking treatment or incurring a medical debt, because the out of pocket expenditure, waiting in long lines at the hospital, paying for the case fees even if it is a nearby local hospital, it becomes very difficult for them to go seek care, and hence healthcare takes a backseat for them because it is compromising on a lot of aspects. Sometimes it might be as simple as compromising on their children's nutrition, so they'll not seek treatment, and hence it takes a backseat. So financial inclusion, digital inclusion, wherein they can get access to telemedicine, or they can get access to simple medical information sitting at home on phone. Even that leads to building resilient healthcare ecosystems. And last but not the least, it is having a holistic and integrated approach. For a lot of members, even like me and you, it is not only NCDs, but it is nutrition, it is menstrual hygiene, it is having proper and on-time access to sanitation, it is having access to real-time information. A lot of us are having a lot of data at present. We are conducting a lot of research, but that is all in silos. How about us all coming together, analyzing those data sets, and then designing interventions that focus on all these points put together and not only one standalone priority?
Thank you so much. That's a lot of information that you put together and shared your lived experience. And I'm waiting to see it in person one day and soon. Sachin Golwalkar was the CEO of Asia Pacific Consulting Advisory India. Now is an independent consultant, used to be with United Way of Delhi, and has raised money for philanthropy and has seen the way philanthropy can be shaped, and also healthcare can be shaped by the philanthropic organizations that actually support all this, that will make it happen. Today, whether it is CSR or philanthropy, one act can change a lot of things. And we've seen how that has actually topsy-turvied the world of healthcare and the last mile delivery. Sachin lived and shared experiences, and it's not an easy world to raise money. Ask me, I live in that world and I dread that world. And I've done it for 35 years now.
Absolutely. And sorry, am I audible? Okay, so I have been in the social impact space for 26 years, and just over this journey, I divided it into 15 years, 15 years. 15 years was largely supported by institutional donors. And there was a lot of focus, like even Dr. JP or Dr. Sundaraman said, a lot of focus on institutional building at the grassroots level. And primarily, one of the reasons for that was also that government spending was very, very low. Government infrastructure was very poor, and institutions had to be built. So governance at the grassroots was a very, very core focus. And it was not necessarily only for health, but it was multi-sectoral. So if I look at that, and from that time to now, yeah, I think I feel that the focus is for the current sector is going to be primarily on change management. You didn't have digital, literacy, because digital penetration was almost zero in many places. Yeah, and to now, where you have got almost digital devices everywhere. Yeah, you actually, the fundraising instruments and fundraising spaces are changing as we speak. They are getting even much more complex for the entire not-for-profit organizations to understand. That itself is a change management for the leadership to take us. How are we going to survive in this competitive environment? And so relatively, it was a donor-led, institutional-led space, but there was a lot of democratic spaces which were created during that period, where the civil society's voices were very much vibrant and visible in various quarters. If you look at the 13-14 and the advent of the CSR space, initially the CSR space was where the corporates also were grappling to understand the nuances of what it means. A lot of projects came in as 1 year projects, like you have the rental agreements. Nobody is willing to commit to the long term because people are trying to understand what is going to happen. A lot of one time programs, and therefore you see also a shift in terms of moving away from the institutional spaces which were created earlier, where there were a lot of investments in those, to a lot of Schedule 7, which activity, which projects relate to which Schedule 7. So the interconnectedness of programs also became very compartmentalized and short term. And obviously the CSR space has evolved quite a bit and evolving as we speak. When we are talking about CSR, a lot of emphasis is not given, or even sometimes that is looked down upon today, is of the intermediary NPO space. The intermediary space, with the ones which were performed by agencies like United Way or say CARE or Save the Children's, where they had a large ecosystem of organizations, of hundreds of organizations under their ecosystem. That has also got dismantled in a lot of senses. So the importance of those players, intermediary players, needs to be also needs to gain relevance in today's change management time, because a lot of smaller organizations are really getting marginalized because they cannot keep pace with what are the changes which are happening around. A lot of great examples in the CSR space. With United Way, we worked with the former government of Delhi on the identifying mental health challenges in government schools. Those were pilots in government schools, and that was a consortium-led approach where a lot of corporates joined hands to support. Where United Way was the PMU, Tata Institute, IBHAS, a lot of other players, Dimhans, they were there. And the commitment from the government was that if the pilots succeed with the research demonstrating its success, then those will be scaled up to maximum government schools with government funding. You have examples like Anamaya, which is also again a tribal health program of the Piramal Foundation. Very unique program. Why I'm mentioning, because it actually connects with the cultural roots of tribal populations. They are looking at codifying tribal medicines. They are also looking at bringing the tribal medicinal folk into the fold of the capacity building in terms of how they can actually deliver certain preventive and promotive health communication. If you look at the CSR again, now we are actually looking at long-term commitments in CSR, because now the guidelines are changed. You are no longer looking at the earlier guidelines used to say that you have to work around your offices, which was a very restrictive. And if you'll see the skewing of the funding, you'll see a lot of funding going into Mumbai, peripherals of Mumbai, Bangalore, peripherals of Bangalore, or around the cities. Very lesser like investments going into the areas which really deserve. But that has also opened up where a certain percentage can be deployed in areas of strategic interest around the Schedule 7. Schedule 7 interpretation has been liberalized. Well, if you look at the COVID scenarios, a lot of interesting experimentation happened with the social enterprise, with Made in India and Viksit Bharat. The ACT fund came into being, where a lot of venture, it's called as a venture philanthropic fund, and a lot of venture capitalists along with big institutional donors came together, and corporates pulled into a massive about 500 crore funding, and a lot of funding went into innovation, social enterprise, and ones who are actually making better PPEs, better ventilators, better telemedicine, and then later on, currently Act for Health looks at scalable technological solutions. So, and a lot of them are using new age cutting technology like the AI ones. For example, a couple of innovations which are there where the device can listen to people coughing and ascertain the percentage of probability of tuberculosis, for example, or say the probability of cervical cancer using technology. So a lot of innovation is happening in terms of that and deployment. Coming back to my point is that a lot of smaller organizations and grassroots democratic, institutional development needs to be brought back into the mainstream. I have less time but to talk about the development impact bonds, but maybe at a later time.
Thank you so much. It's a panel that I can take on for a whole day, and each of us, I haven't even spoken about what we do at Access or what we have tried. But I'm just going to take one point from each of you to close the session. Professor Sundaraman, pathways and purpose. And you have shown that pathway and purpose and demonstrated it across at least 4 decades or more. And we'll keep coming back to you for more on that. Prabhat, your ABC is very well taken. Acknowledge, build, and make sure there's collective action. Ratna, experts at par with healthcare providers, patients who are long-standing patients can teach some of the younger doctors better than who they can actually be. And one needs to be able to listen very well. Rajvi, you talked about holistic, integrated approach, something that we can never have enough of. And of course, the information is never an information overload. Sachin, ours is a very sensitive subject. When we have to raise money and we have to give money away, it's not easy. But change management and how to change with changing times in terms of making sure that you have the right amount of money to be able to put that together. Prabhat, the one thing that I have, which my team has done for me very well, is make sure they give me the 16 points. And it just shows how old I am and how it's getting. Community at the center is what we believe in at Access Health. Community at the center is what we believe at the Global Learning Collaborative for Health Systems Resilience. I'm grateful for each of you who have traveled long distances to be here this morning to share with us. We have run out of time, so I'm going to go on to the next panel. Thank you so much. Can I get a picture with all of you?